Welcome to today's webinar, Preparing Your Maternal and Neonatal Units to Respond to COVID-19 Practical Recommendations from a Frontline Hospital on behalf of CMQCC and CPQCC. Reach out by chat if you have technical issues. We have done our best to compile several questions from the hundreds already submitted, and those will be addressed at the end of the presentations. We will continue to 12:15 with the question and answer segment. We will not be addressing any additional questions submitted during the live session. Dr. Main, I hand it off to you.
Good morning, everyone. This is Elliot Main, the Medical Director of CMQCC. On behalf of both CPQCC, our neonatal arm, and CMQCC, the maternal arm, we welcome you today in this time of unprecedented national worry and concern over this new virus and how it affects the obstetric and neonatal services. This is particularly hard as we need to move forward with limited data and limited science. So we are blessed today with a panel of experts who have been working on this over the last month or more, representing infectious disease, obstetrics, nursing, infection control, pediatrics, neonatology, and disaster planning. So it's a fabulous team. And we want to share today our current thinking, recognizing that it may change in the next days and weeks, but at least it is where we are now from a group that's been in the trenches. Next slide, I want to turn it over to Dr. Henry Lee.
Hello, everyone. This is Henry Lee, Chief Medical Officer of the CPQCC, and I just want to extend my welcome as well. And just appreciate everyone just joining in part of this community as we work on this together. Many of these abbreviations and terms have become familiar to all of us in the recent days, and you're probably already sort of in the thick of it, but just in case, I just want to lay out these abbreviations and terms that will be presented throughout this morning. And SARS coronavirus 2 is the virus that's affecting all of us today. COVID-19 refers to the disease caused by the virus. PI, or person under investigation, is somebody who's potentially having the virus and being tested. PPE, personal protective equipment, which we'll go over more, healthcare worker. AIIR stands for Airborne Infection Isolation Room. AGP, aerosol generating procedures. And when we talk about enhanced droplet precautions, we're saying that someone should have a gown, gloves, procedural mask, and eye protection that's more than just glasses. Airborne precautions refers to having an N95 mask, eye protection, gown, and gloves, and PAPR or PAPR, personal air-powered respirators, if someone has not been tested for N95. So next, I want to hand it over to Dr. Natali Aziz, who's a maternal fetal medicine specialist at Lucile Packard, Stanford. Dr. Aziz.
Dr. Aziz, I think you're muted. If you can unmute your line, then we can hear you. Oh, we're not hearing you, Dr. Aziz.
Can you hear me now?
Yes.
Yes, so we can.
I'm sorry.
Yeah.
Okay, thank you so much. Can we go back to the first slide? Good morning. Thank you again, Dr. Lee and Dr. Main, and thank you for your contributions to the care of mothers and infants throughout California through your efforts in CPQCC and CMQCC. So my portion of the talk is regarding the testing criteria and what we are led to test in terms of appropriate patient candidates. So when we start out on a broad level, the CDC testing criteria is a few-fold, and it first includes hospitalized patients who may have signs or symptoms of COVID-19 infection, other symptomatic individuals like older adults or those with chronic medical conditions or immunocompromised state, and then finally, any healthcare personnel, including those that may have had a 14-day symptom onset with a close contact with COVID confirmed patient or with a history of travel to a affected geographic region within the past 14 days. Now, please be aware that the geographic regions are currently China, Iran, most of the European countries, UK and Ireland. However, this is always changing, and I have placed the URL for the criteria for travelers, and we can always quickly access the CDC for the most recent countries of travel. Close contact is also defined by a location within 6 feet of a COVID positive individual and prolonged period of time or direct contact with infectious secretions. Thank you. Next slide, please. Next slide, please. Now, going from a broad level of CDC criteria to a more refined level, the ACOG and SMFM criteria is similar to the CDC, and they state to actually refer to the CDC. Now, given that pregnant women usually fall under a special criteria of patient populations, we actually tailored our testing criteria for that specifically. So at Stanford Children's Health, with the guidance of our infection prevention and control team and our obstetric colleagues, we came together with a joint criteria for testing individuals. Now, generally, this will be anyone with acute respiratory symptoms, whether it's upper or lower tract, and one of the following, and either fever can be present or not present. And it includes requires hospitalization admission. So if a pregnant woman comes in, she has symptoms and she's requiring admission, then she needs to be tested. If a pregnant patient is in the hospital, let's say for preterm labor, but she develops symptoms within the past 2 weeks, for example, or thereafter, she also requires testing. And then women who have special immunocompromised states. So those would include things like chronic medical conditions, such as immunocompromised, diabetic, autoimmune patients, such as lupus, for example. And then finally, the traditional criteria of close contact with a COVID-19 person plus symptoms or travel plus symptoms meets criteria for testing as well. So in a quick little summary, if we go to the next slide, this is just pertaining to pregnant women at our hospital. So basically, for summary of pregnant patients at our hospital currently, we are testing for women who have either respiratory or influenza-like symptoms, plus or minus fever, with either COVID-confirmed exposure, travel to a high transmission region, and remember to always access the CDC for most up-to-date guidance, respiratory or influenza-like symptoms, plus or minus fever, who are actually hospitalized, or those with symptoms who have high-risk conditions such as immunocompromised status, autoimmune disease, diabetes, or other conditions per the discretion of the OB. And on the next slide, I have just a few conditions that the CDC considers high risk, especially for severe COVID infections, and that includes hypertension, diabetes, asthma, HIV infection, chronic heart disease, chronic liver disease, chronic lung disease, chronic kidney disease, blood dyscrasias such as leukemias or other hemophilias, for example, and then immunosuppressive therapy. Next slide, please. And with respect to upper testing and lower tract testing, The specimen collection is of the nasopharyngeal or oropharyngeal swab. Now, most recently, the CDC has given us more guidance and is now recommending collecting only the nasopharyngeal swab, and we use the synthetic fiber swab, which is a viral transport media. Oropharynx, however, is still acceptable. For example, if somebody is not able to tolerate a nasopharynx swab, you can still perform an oral pharynx swab. And if you happen to do both and perform both on a patient, then both specimens can go into the same tube. For the nasopharyngeal swab, you insert the swab into the nostril parallel to the palate and basically are able to reach the distance from the nostril to the outer opening of the ear, and you place it there for several seconds. And for oral pharyngeal swabbing, just swab the posterior pharynx, avoiding the tongue. Finally, for nasopharyngeal wash or aspirate, you collect 2 to 3 cc's leak-proof in a screw-top cap and or a sterile dry container. For the lower respiratory tract, which is our next slide, specimen collection, that would include bronchoalveolar lavage or tracheal aspirate, which usually is done during endoscopy. So we're typically not involved in those procedures as obstetricians. However, sputum may also be collected, and the patient rinses their mouth with water and then expectorate with deep cough sputum directly into the collection cup. Thank you. And then next slide, please. So the diagnostic testing at this time is using real-time reverse transcriptase PCR. These are available through local and state Department of Public Health organizations, as well as commercial laboratories such as Quest, and as well as university institutions. For example, at our institution, our Stanford Virology Lab Director, Dr. Benjamin Pinsky, was able to FDA approve one of our internal in-house testing, where we have a turnaround time of about 12 to 24 hours on an ideal condition or situation. Now, given the exceeding number of tests that are being run, obviously sometimes these tests can take longer to return in terms of their results. And most recently, Cephayad, which is a Northern California company, just released point of care testing, where the turnaround time is about 45 minutes and it can be performed at the bedside. So those are some of the newer tests that are being developed. Additionally, culture is available, but we prefer the PCR because it's faster return. And then finally, antibody testing is not used standard at this time, but is being developed currently by various laboratories. Next, please. This is just a brief explanation of nasopharyngeal sample collection for individuals to reference back to. Next slide, please. So this is just a very brief description of, once the patient is testing positive and she's pregnant, what are the isolation criteria for discontinuation of the patient, for example, from her home isolation. So in COVID-19 positive patients, they can either stop home isolation based on 2 different plans. One is the non-testing plan. So if a test is not planned, and to determine if a patient is still contagious, the following 3 criteria must be met. So the patient has no fever for at least 72 hours without the use of antipyretics, and the symptoms have improved, and it's been 7 days since past symptom onset. For the test strategy, where a test is planned and to determine if a patient is still contagious, the patient no longer has a fever without the use of antipyretics. However, there is no time criteria for that, and their symptoms have improved, and the patient receives 2 negative PCR tests in a row 24 hours apart. And this is per the CDC guidelines. Again, this all can be accessed through the URL on the bottom of the slide. Next slide, please. And this was a very interesting example of how OB and infection prevention teams can work together to really decide what's best for a patient's case. For example, we had a patient I was informed about who is a gravida 1, para 0, at 36 weeks gestation, who presented with a fever and a cough. And the patient was tested at an ambulatory setting, and she was COVID-19 positive. Currently, she's on home isolation, and our really question is, when is our patient going to be off isolation and be able to come into the hospital or come into the clinic without a COVID positive necessity for isolation? So in this case, having wonderful colleagues like Dr. Roshni Mathew, who will be speaking later, who's the co-director of our Infection Prevention and Control Department, we worked together and she came up with a hybrid for this patient. Given that the higher risk case where the patient is likely to deliver soon, the baby would also then be considered a PUI if the mom is still positive, or if she's not, then the baby would not be considered a PUI. So with this respect, we came up with a plan of resolution of fever for 72 hours and improved symptoms at least 7 days from the onset of illness, plus 1 negative test. So as you can see, we made a hybrid, and we do think that some of these cases, given the complexities of pregnancy and the complexities of delivering and considering the infant considerations as well, kind of takes this teamwork. So we really think that, you know, these types of strategies are always helpful to collaborate both with OB, your pediatricians, and your infection prevention control. So next slide, please. And these are just a list of resources for easy access. So including the clinical criteria of diagnosis, testing, in-home isolation discontinuation, and specimen guidelines, as well as the ACOG criteria and SMFM criteria. And thank you. That's the end of my portion of speaking. Thank you.
Hello, everyone. This is Roshni Mathew. I'm one of the pediatric infectious disease physicians at Lucille Packard, but I work very closely with obstetrics and neonatology and all across the hospital in my role with infection prevention and control. My slides very briefly are going to talk about pregnant, either PUI or COVID positive pregnant patient and patient placement. There is no specific guidance for obstetric patients through CDC, and they essentially direct you to the interim guidance they have for any patient who is a PUI or COVID positive. So the language is essentially, if admitted, place a patient with known or suspected COVID-19 in a single person room with the door closed. The patient should have a dedicated bathroom. Airborne infection isolation rooms should be reserved for patients who will be undergoing aerosol generating procedures. And we have a list of aerosol generating procedures that we use essentially to enable us to decide whether an AIIR room is required. Next slide, please. Just very briefly, because Kelley after me is going to go into details about PPE. With regards to isolation precautions in our L&D and maternity, when a patient who is a PUI or COVID positive pregnant patient presents to L&D, the AIIR room is preferred, but since that is there are only few options for that. If unavailable, then the L&D room, another L&D room designated would be used with a HEPA filter in place. If operating room is going to be used, again, a designated OR with HEPA filter in place would be used. In maternity unit, this pregnant patient would go into an AIIR if available, but otherwise a single patient room would be used. Isolation sign would be posted outside the room with PPE card. Only one labor support person is allowed who dons a procedure mask throughout. The staff caring for the patient has to fill out a staff tracer sheet. And essentially, with the goal of limiting PPE use, we are at a point where we have to limit providers entering the room. This would also be important just in terms of exposure risk. Thank you. I will hand it over now to Kelley.
Hi, my name is Kelley Brennan Lee. I am a RN and a women's health nurse practitioner, and I'm currently working at Lucile Packard Children's Hospital, Stamford, in the role of clinical practice specialist. So I'm going to talk a little bit about the PPE recommendations for staff when caring for pregnant or postpartum PUI and COVID-19 positive patients, and then Dr. Alexis Davis will speak more about the newborn PPE. So for laboring or C-section patients, we are using airborne plus contact isolation, and as Dr. Mathew said, we are placing them in airborne infection control rooms due to the risk of the possibility for aerosol generating procedures for mom or baby, including intubation, CPAP, or PPV, and this would apply for both the labor room and the operating rooms. The PPE should include a single-use N95 mask or higher, including the PAPR or CAPR masks if a staff member has not been fitted for N95 or failed the fit testing for N95. Eye protection in the form of goggles or a face shield should be used at all times, gown and gloves. Next slide. The PPE is the same for antepartum or postpartum patients as well. The only difference here is that if there is a shortage of AIIR rooms available for postpartum or antepartum patients, they can be placed in a single patient room with the door closed and utilizing a HEPA filter because there's a lower risk of needing to perform any aerosol generating procedures on these patients. Next slide, please. The recommendations for PPE for the support person. Currently at our hospital, we are only allowing one support person for the duration of the admission for labor and the postpartum period. And we do recommend that that support person should wear a surgical mask at all times. They should remain in the room with the patient at all times, with meals being brought to the room and using the bathroom in that room. And additionally, they should wear gown and gloves when in direct contact with the patient or providing care to the patient. For example, labor support, assistance with repositioning or toileting. Next slide, please. We have had a lot of discussions at our hospital regarding PPE for the anesthesia providers during intubations. Currently, we are following the CDC guidelines for intubation of PUI or COVID-19 patients utilizing an N95 mask and eye protection or the CAPR or PAPR respirators. These N95 masks should be single use and discarded after patient care and after the intubation. For the intubation of non-PUI and COVID positive patients at Stamford, we are currently also using N95 masks and face shields by the anesthesia team. Again, this is the current guidance at our institution, and it's being utilized due to the high prevalence of community-based transmission and the possibility of asymptomatic patients to protect our anesthesia providers. Next slide, please. So as we've all heard across the country and in our area locally, there are PPE shortages, and the CDC does recommend certain PPE conservation strategies. The first is to minimize entry and exit into the room and the need to change PPE. So ideally, the care team should cluster care. And for example, the RN would perform all of the patient care duties that are possible at one time rather than having multiple entries and exits into the room, or that RN would remain in the room as much as possible, keeping a distance of greater than 6 feet from the patient when not providing direct care and utilizing their PPE. Cohorting positive patients together when needed, so putting them into the same area of the hospital or even the same room when space and facilities run short, so that you can minimize the use of PPE. And the recommendation is to change gowns and gloves in between patients, but that the N95 mask and goggles can remain on in between patients. The recommendation is to minimize the providers caring for the patient whenever possible, provide one-to-one nursing care, and the attending provider cares for the patient whenever possible or an upper-level resident if necessary, rather than having a junior resident attend to the patient that may possibly need additional assistance from an attending or an upper-level resident, thus bringing an additional person into the room. you want to focus on having the minimum number of providers to safely care for the patient during any procedure. And if additional providers might be needed, it could be a recommendation to have those providers available right outside the room, able to quickly don PPE and enter the room if needed. And Dr. Davis will speak about that more in terms of the NICU teams later attending deliveries. Additionally, we've been exploring the option of having questions or consults done via phone or video from other services that do not need to examine the patient. For example, if the patient has more questions for the NICU team regarding isolation for the baby, could that be done via phone or video conference rather than having the NICU team come into the room for that consult? Next slide, please. There are some additional considerations for facilities that are facing significant shortages of respirators that would include N95s, poppers, and cappers, and the CDC does provide guidance saying that surgical face masks and eye protection can be used instead of a respirator in those situations. If necessary, based on supply chain constraints, facilities should prioritize the use of respirators for aerosol generating procedures. And when normal supply chain is restored, the recommendation is to resume the use of respirators for all PUIs and COVID patients. Next slide, please. This provides guidance from the CDC for the proper sequence of donning and doffing PPE. So the provider should perform hand hygiene, place the gown, then the N95 mask, followed by goggles or face shield, and finally the gloves, and those should be pulled to cover the cuffs of the gown. And all of this should be donned outside of the patient's room prior to entry. Next slide, please. It's especially important to doff the PPE in proper sequence to reduce the risk of self-contamination as well. So while still in the patient's room, the recommendation is to remove the gown and gloves and perform hand hygiene. The provider would then exit the room into the hallway or the anteroom if it's a double door isolation room, and remove goggles or their face shield, perform hand hygiene again at this time, then remove the N95 mask and perform hand hygiene for a third time. Next slide, please. I'm going to pass this on at this point to Dr. Alexis Davis and Roshni Mathew.
Thank you, Kelley. So first, I just want to start with some assumptions that we are making along with CDC guidance about, as well as the literature, about coronavirus and implications for unborn and newly born babies. Based on a recent report in The Lancet from Wuhan, China, we feel that the risk of the fetus being infected through vertical transmission is quite low. It was a very small study with less than 10 infants studied, where they tested amniotic fluid, cord blood, and breast milk, and did not find virus in any of those samples. So that leads us to conclude that the greatest risk for perinatally acquired COVID-19 is through contact with respiratory or droplet secretions from the mother or other affected caregivers. If those of you on this call are part of the section on neonatal and perinatal medicine, you might have received a document from our president, Mark Hudak, that was authored by Karen Popolo and David Kimberlin, who are notable experts in neonatal infectious disease. And that document is quite extensive, and I'll point out some commonalities and or deviations from our practice from that document. But in this document, it does discuss a theoretical risk of transmission through urine and stool during the delivery process. The other assumption that we make regarding babies with respiratory infections is that they do not readily aerosolize secretions on their own. That is, they can't generate a strong enough cough to aerosolize secretions within any sort of significant radius. Next slide. All right, so just to reiterate some things that were said previously, we are making the presumption that infants who are born to PUIs or those confirmed to be positive for COVID-19 are also considered to be PUIs. The guiding principles as we approach how we manage these newly born infants is that, number one, we do need to provide standard of care through the neonatal resuscitation program. And while doing so, we also need to protect our healthcare workers to the greatest degree. So certain local considerations that you will need to take into account include what real estate do you have to resuscitate these babies? Are you limited where you need to do this in situ in the mother's labor and delivery room? Or do you have a setup where you might have a separate room adjacent to the mom's delivery room to manage the infant? And some of this might also be dependent on the availability of airborne isolation rooms. Our stance at Stanford has been that the postnatal transition can be unpredictable, as anyone who goes to deliveries knows, and therefore we have to be prepared to execute. And in doing so, we consider positive pressure ventilation, CPAP, or intubation to be aerosol generating procedures. And this has led us to conclude that we need to take the highest level of precautions, both for healthcare workers and transmitting into the environment. So that's the rationale for having the moms in an airborne isolation room. With our delivery room preparations, when a PUI or a known COVID-19 positive mom is admitted to labor and delivery, we have a clear line of communication between the NICU and labor and delivery to allow us to hopefully be able to put the correct equipment in place and notify our team members. This again includes the mother in an airborne isolation room or one which is either a double door or one that is retrofitted with a HEPA filter. We will ask the personnel present at the delivery to don airborne precautions, including eye protection. And then in our unit, we have decided whenever possible to resuscitate the baby in an open incubator. We have giraffe omnibeds with shuttles so that we're able to have our resuscitation equipment connected to our incubator bed. And in doing so, we can both perform resuscitation as well as close the baby up for transport to whichever unit that we determine should be triaged to. If we don't have time to do that, we will, our fallback is an open radiant warmer, but we would transfer the baby to an incubator upon exit from the mom's delivery room. Next slide. One other thing that has been recommended by our institution, our respiratory therapists, is using a special filter between what is considered an open system using a T-piece, as well as a flow inflating bag. So you can hopefully see on this slide in between the end tidal detector as well as the T-piece on the left, there is this is a filter. So this is to, again, minimize aerosolization of respiratory secretions. And then you can sort of see that on the right-hand side. Next slide. So for our delivery room response team, I will say that this is constantly under discussion and in flux, but our goal is to balance PPE preservation and protecting our healthcare workers. So we're trying to put only the minimum necessary personnel into each delivery room. The next three bullets really kind of describe our tiered system for responding to the deliveries, and then the indents describe how we are implementing that in the setting of a possible PUI delivery. So most uncomplicated deliveries, we're not usually called. However, in this case, because of the need to rapidly respond and don PPE, our decision has been to basically place our team outside the LDR and wait to be called if needed and respond very quickly. Again, this is trying to balance the use of PPE with our need to be there. If it's a standard delivery, and this is typically one where a hospitalist and a nurse are called to respond, these are things like decelerations or late preterm infants or just a routine cesarean section. So our regular standard team responds and will don PPE. An RT does not typically respond, but we will also have them notified and waiting to enter with that specialized filter equipment if necessary. We increase the number of providers, but hopefully try and keep it to a minimum for those more complex deliveries, particularly as it relates to extreme prematurity or other congenital anomalies. And even with these deliveries, the decision to include an RT might depend on what that particular delivery circumstance is, but obviously with a low threshold to have them inside the delivery room. Next slide. So the next few slides will just describe our triage thought process for infants who are either asymptomatic or requiring admission to the NICU. Currently, the CDC is recommending separation of mother and infant, but there is language to allow the baby to stay in the mother's room. We are actively in the process of creating an educational document for parents to review prior to delivery and possibly in combination with consultation with the NICU team to discuss the risks of horizontal transmission, since that's the underlying basis for separating the mom and the infant after delivery. We understand that that's going to be a potentially very sensitive discussion to separate mom and baby after birth when the baby is asymptomatic. So we're going to provide this document, but not enforce separation as a hard stop. Understanding that different families may have differing levels of risk tolerance, and this might also be influenced by the mom's symptomatology, as whether she's more mildly symptomatic or more floridly symptomatic. So if the parents agree to the recommendation to separate from mom from baby, the baby will be placed in a single patient room in our maternity unit and put under enhanced droplet precautions. Because the baby will be separated, obviously this baby will receive express breast milk, and we can offer donor milk if the parents desire. And because this labor support person is considered a direct contact, we are not permitting visitation at that time. Understanding that, again, with the sensitive nature of separating mom and baby, we will permit parents to decline that recommendation and opt to have the baby in the mom's room, in which case we will have the baby in an incubator at least 6 feet from mom. The recommendations, because mom is a PUI, is for airborne precautions and eye protection. We will primarily recommend that the infants receive express breast milk, because this is what is recommended by the CDC, again, to prevent horizontal transmission. But after education, if the mom declines and chooses to directly breastfeed her infant, she will be asked to wear a mask. With this option, the labor support person will be in the mom's room because he was previously in mom's delivery room. But again, because he's considered a direct contact, will be asked not to directly participate in the care of the infant. There are some practical considerations with this type of decision tree. When you have babies in separate rooms, there will, of course, be staffing considerations to take into account, as well as exceeding capacity of maternity rooms, depending on how busy labor and delivery is at the time. Next slide. And this is how we are deciding to selectively room infants who require admission to the NICU. This may be because they have respiratory symptoms, either perhaps more likely not related to COVID-19, but due to prematurity, but also infants perhaps more moderately or late preterm infants who require admission or for other reasons. Because we're considering really any sort of respiratory support, and I'll talk about alignment with larger institutions on a later slide. Really any non-invasive or invasive respiratory support in our institution is considered an aerosol generating procedure. If an infant does require respiratory support, we will place that baby in a negative pressure room. We have 4 of them, but also put the baby in an incubator to minimize aerosolization to the environment to protect the healthcare worker. Obviously, the baby will be separated from the mother at that time, and feedings would be primarily through express breast milk when the baby's stable. If an infant does not require respiratory support, the infant can be roomed in a single patient room or a semi-private room, again, placed in an incubator to protect the environment and healthcare workers under slightly different precautions. And in both instances, because we have a unique at-risk environment in the NICU, and because the labor support person is considered a direct contact, they are not allowed to enter the NICU. We understand that that's going to present a significant challenge for all of our units because family-centered care has become really paramount in how we approach care for babies in the NICU. Our hope and our guidance to the families is that we hope that this can be temporary until we know the results of mother's test. Next slide. So as far as testing recommendations for newborn infants, I'll make a quick statement and then I'll let Dr. Mathew take over. If you received the document from Karen Popolo and David Kimberlin, they have some fairly aggressive testing recommendations, including PCR testing of the nasopharynx, throat, and rectal swabs at 24 and 48 hours of life. And all 6 swabs must be negative to be ruled out for COVID. And then I'll let Dr. Mathew talk on the next slide regarding our local guidance at Stanford.
Thank you, Alexis. Can we move over to the next slide? So we have not had an instance of having to do this. So this is a proposed plan for an infant born to a confirmed COVID-19 positive mother. So in these instances, although the vertical transmission is still debated and we will probably come to know more in the days to come, we do not also have any evidence that it is in the vaginal secretions. However, again, something that is yet to be published. So at this point, for all COVID positive mothers, the babies that are born are considered PUI. And our proposal is that they would be in an isolation for PUI status for the next 14 days. And then I split it into term newborn babies who are potentially going to be discharged in the next 2 to 3 days, and then the other side as newborns who would require to be hospitalized during that period of time. For a term healthy, on the left side, the term healthy newborn that's planned for discharge, both of those groups actually would get a nasopharyngeal testing done at 24 hours of life. This is the testing platform we currently have at our hospital. So this is a validated test, and stool and urine and all of those other specimens are not currently validated. So for us, from a logistical standpoint, this makes most sense. So if the 24-hour, once the 24-hour testing is done for the term healthy newborn baby that was expected to be discharged anyway within the stipulated 2 to 3 days, if the baby is healthy, the baby would go home, and the guidance is per any other routine discharged patient who may, we would give guidance around what to expect if it's positive, what to expect if it's negative, things like that. As anticipatory guidance to the family. If the baby is staying in the hospital and the 24-hour testing comes back negative, the baby would remain in isolation because of the incubation period of 14 days and retesting if new symptoms develop during that time frame. This could be anything from respiratory symptoms to a new fever to liver enzyme elevation. Anything that is suspicious of a viral infection would essentially cause the baby to have another test. If the test is positive, we would still maintain the isolation for the duration of 14 days. And then the retest would be more for removal of isolation at that point, and so would use a strategy like the CDC recommends for healthcare workers, which is to retest once asymptomatic. This is a proposed plan. Obviously, all of these are subject to change as we learn more and more about this disease in the newborn. Thank you. I will hand it back to Dr. Davis.
Thank you. I think in the interest of time, I won't go into too much detail on this slide. For units that admit outborns, for example, infants who might present with a fever and require admission for evaluation for sepsis, this raises questions about whether these babies should come into the NICU if there's concern for COVID. So in discussion with our acute care and PICU colleagues, we have elected for the time being to not admit these babies who have already pass through the newborn transition period and selectively admit them to either acute care units or to our PICU so that we can prioritize our isolation rooms for the newborn PUIs. From a testing standpoint, we are concurrently running a respiratory PCR panel and COVID concurrently. Next slide. And then other clinical considerations that have come up as we are all on this journey together. I've had situations where a mom is identified as a PUI after delivery in a somewhat delayed fashion after a baby might have already been evaluated and triaged. And I think certain situations to think about are a mom who develops fever and whether we would do our usual diagnostics thinking about choreo, or this now rises to the level of being a PUI. Similarly, other respiratory symptoms that may develop after delivery, such as pulmonary edema from magnesium or amniotic fluid embolus, and requiring escalation of respiratory support might also require mom to be labeled as a PUI, depending on your institutional standard. And so this has implications for exposure to other babies in the newborn nursery or to mom, and we're still working through that. We've also had an instance where a baby presented with a fever and GI symptoms in the absence of respiratory symptoms, and the question is whether you test for COVID circumstance, since we know that GI symptoms have been reported in about 30%, up to 30% of COVID cases. And then what do you do with NICU infants who have been in the hospital this entire time and then develop respiratory symptoms? Are they considered a PUI at that point, and how do you triage them? So I don't think there's easy answers to those questions, but things that we're all working through in real time. Next slide. Just want to say one more thing about alignment challenges for large healthcare systems. If you're part of a healthcare system that is developing guidance for adults, there are sometimes circumstances where there might be opportunities for misalignment. I think one example is how you interpret these CDC guidelines. I think they're written to provide guidance, but allow flexibility to adapt to local circumstances. And those local circumstances may be different between adult and pediatric units. And so how do you resolve those differences? So that's something that our institution does on a daily basis with representatives from both sides. I think an important deviation that we are doing from Stanford, where for adult management of COVID, there's a recommendation for early and empiric intubation to avoid things like non-invasive respiratory support to prevent aerosolization. And we're really choosing not to adopt that because of all the data in neonatology that really supports non-invasive support as being superior in optimizing lung outcomes. And so that's our rationale for placing babies in an incubator to minimize exposure to healthcare workers. So I'll hand it over to Dr. Daniels now to talk about surge planning.
Good morning, everybody. My name is Kay Daniels. I'm an obstetrician and co-director of disaster planning for the Johnson Center. We're going to pivot a bit to talk more in terms of what to do if you start to find that you are having overcrowding or having capacity problems. And here I'm going to present some strategies to help you figure that out. For those of you who are not well versed in disaster planning, we use the word surge as a way to explain when we have an overabundance in patients. And it comes in 3 different levels. Conventional crowding surge is something that anybody who works on an OB unit understands. It's when the moon is full and there's all sorts of patients coming in, but you're okay. You're managing, you're working hard, but you're managing them. The next level is contingency capacity, and that's when you are really starting to be overrun. That what you have been able to do with overcrowding is no longer sufficient, and your supplies are not consistent with daily practices. And that's what we're going to talk about today. The third is called crisis capacity, and that's when you have really been overrun, when a truly catastrophic disaster has happened. So we're just going to deal with contingency capacity, where to go once you have gotten past your usual level of overcrowding. Next slide. When you talk about surge and contingency planning, it's really nice to put into these 3 spaces, 3 categories: space, staff, and supplies. So anytime you're going to have to go over what you're used to doing, you're either running out of space, you're running out of staff, or you're running out of supplies. So we're going to talk about each one of those. Next slides. So starting with space, if you're starting to get too many patients or patients that need to be in single rooms because they're PUIs, you can no longer use your double rooms. How do you open up more beds on your unit? And here are some ideas which some of you probably have already seen. You start with canceling the elective procedures whenever possible. You start to do expedited postpartum discharges. This will increase your postpartum beds and allow you to have more single beds for your PUIs who have to be in a single room. And you can shorten your hospital stays. This is all dependent on the patient, obviously, but for many of multips, they're happy to get out in less than 48 hours. This is also dependent on when your pediatricians are willing to let the babies go. You can also consider shorten the stay for uncomplicated cesarean deliveries. The next step, that's sort of the usual things we can do. Now we start to think about how can we repurpose rooms specifically for our surge needs, and which of your rooms can be used for the COVID-19 labor rooms that can either be negative pressure, or the new term is the AIIR pressures, or where you can put a HEPA filter, because you can't put HEPA filters absolutely everywhere and also be able to have a bed and a warmer in there. Then you need to start thinking, when you have a lot of these patients, whether they're PUIs or COVID-19s, where can you start cohorting? And someone mentioned that before. If you have a certain area of, say, 4 or 5 rooms where all your either PUI or COVID-19 patients are living, you can make sure that your staff, there's 1 staff member or 2 staff member that's taking care of those patients. They can often reuse their masks, not their gown and gloves, but they can be reusing their masks. And importantly, there are going to be people that are going to be doing this constantly. They'll know how to don on and off. So you don't want to mix up your staff with these sort of high-risk patients. So the advantage of cohorting will allow you to save equipment and supplies. Next slide. Then we want to talk about staff. So in this kind of situation, yes, we may need more space, but maybe in the end, our issue is staff. Now our staff is going out with the disease, and we don't have enough staff for all our normal number of patients. So here are some strategies about what you can do to stretch, to multiply your functional nurses. One of them is changing the nurse to patient ratio. How can you do that? Well, because a lot of the elective surgeries and other cases have been stopped in the other parts of the hospital, there are regular non-OB med-surg nurses who may be available to you in the labor pool to come up and help. And what you can do is use those med-surg nurses to do the routine taking of blood pressures, vital signs, care of the patient, reserving your labor and delivery nurse to do the OB-related issues that these med-surg nurses can't do. And that will be reviewing the fetal heart tracings, magnesium, oxytocin drips. And this will allow your 1 labor and delivery nurse to be able to care for more than the 1-to-1 or 1-to-2 that A1 and ACOG proposes. In addition, if you have centralized monitoring, you may have the option of stationing a nurse in shifts to watch the strips for everyone and have the phone numbers of each of the nurses to alert them if an abnormality is seen. Sort of an extra safety net for the fetal monitoring. You can change the responsibility for documentation. Review what A1 and ACOG already recommends as documentation. I know that we tend to document more than what the standard is, but in addition to that, when you're in a contingency disaster position, you can choose to do less documentation as long as you have a plan in place and that you have reported that to the state. Other options for the staffing of RNs that are still have remained healthy is if you do 8-hour shifts, asking them to come for 12 hours, or even if you're really in a pinch, from 12 hours to 16. And the institution should be willing to offer incentives. And then, of course, the reassigning of nursing administration staff to help with patient care. So that's some of the thoughts about stretching your RNs, and you'll need to talk to your nursing staff about exactly what protocols you're going to write up for that. The next is what happens if our docs start going out? And again, a real possibility. So you can consider consolidating your MD groups. Many of our hospitals are made up of multiple private groups that all work in the same hospital. Well, everybody will be in the same boat, and we may choose to consolidate all of our groups and then have one person be covering the labor and delivery for multiple groups. If you're in a teaching hospital, you should consider your fellows and your senior residents of being able to provide care without direct supervision. And the next point I'm going to make is the idea of keeping MDs in reserve. If you have the possibility of allowing an MD to work straight on labor and delivery for a week as, say, a hospitalist, that may allow you to have somebody on reserve in case somebody goes out. But keep in mind, if someone just gets an exposure and they have no symptoms and not immunocompromised, they are allowed to return to work. So that's only in situations an MD needs to be taken out if they're actually ill. Look around for your OB, other OB available people. I'm sorry, point 4 is don't let your OB-GYNs cover both OB and GYN if at all possible. What you don't want to happen is to have someone going down to the ED for GYN consults, and then as soon as they're done with the GYN consult, to come running up to OB to do a delivery. You've got a higher risk for cross-contamination with COVID since it's so high in the ED. And then look at your non-MD providers. Do you have an MP that's working in your office? Can they help do postpartum rounds? Do you have CNMs that you can also use for a higher level scope of practice? So those are all options for extending your MD, CNM, and NP use. Next is supplies. So supply shortages, we've just starting to touch on and trying to figure out. The first thing, of course, that comes to mind is fetal monitors. And we've talked about using Dopplers, intermittent monitoring for low-risk patients. We've also talked about using the fetal monitors for 2 patients by using it in the twin mode. Oxygen is another issue that when you're doubling up in a room and you've got 1 mom and 1 baby, but you need to also put another mom and baby in there for postpartum, but you are required to have oxygen available for both. You can talk to your engineering people about getting splitters that will allow you to use oxygen for both, but you need to talk to your engineering people specifically about your situation. Next slide. So this is the information about extending our PPE. If you haven't seen these guidelines yet, they're on the CDC, and they're talking about how you can reuse N95s, so that's available to you. There's a lot of talk out there now about extended use. They're even talking about UV lighting, so there's going to be a lot more information coming about N95s. Next slide. And be alert about the issue of blood shortages. I'm guessing that you've probably heard that people aren't coming in to supply blood, and there are guidelines that will talk about when you should transfuse and how we can conserve our blood supply, because this is obviously very important for us to have, so we don't want to waste it. Next slide. The governor's suspension, this is something important that you should understand. When the governor declares a disaster, It gives us a lot of flexibility in terms of all those issues I talked about in terms of creating protocols for nurse-patient ratio. So when the governor suspends regulations, as long as we have a plan in place for that we can then give to the state and say, we've thought this through and this is what we think we can handle, you'll generally be covered. At this point in time, there has been a declaration of an emergency status for COVID-19. So I would have everybody start working on their plans now to present to the state. Next slide. I just want to put forward to everybody on the call that we're going to be an OB disaster planning webinar that's going to be this Friday. That's the invitation. You're all welcome to come join us. This is a group that's been going on for a couple of years trying to do, come up with protocols for OB disaster. We're going to dedicate the one this Friday to COVID, and it will be, we'll be having a speaker from the CDC. And it's a way of just particularly OB providers and managers to talk about things that have been working for them, lessons learned, and lessons of things not to do. So with that in mind, I will let the next person talk. Is Alexis?
Yes, just a quick slide about surge planning for the NICU. As I mentioned, we're grateful to have at least 4 isolation rooms in our unit, but are concerned that that may not be enough. And recognizing that many of us are subject to older open-bay style accommodations that might not be able to provide airborne precautions. This may be the case also with smaller and lower level NICUs that don't have isolation capacity. And so for that reason, based on the triage that we're proposing and with our network of nurseries, we're acknowledging that some of these babies who are going to be PUIs and requiring respiratory support may require transfer to a regional NICU for continuing care. We are worried that that will then begin to exceed our capacity, in which case we're in active discussions about overflowing either to the PICU with NICU consultation. We have separate nursing staff, and so it makes it difficult to just transplant our team over there. So we're working on plans for that. But we're also in discussions with our facilities about whether we can create an open bay room to cohort our COVID PUI babies, again, keeping them in incubators who don't require aerosol generating procedures and therefore are at lower risk. So these are some things that your unit might need to think about depending on your overall hospital's capacity. Next slide.
This is Kelley. I'm just going to speak for a couple minutes about considerations for pregnant healthcare providers. And this comes from the CDC. The data is very limited about the susceptibility of pregnant women to COVID-19. And they suggest that pregnant healthcare providers should adhere to general infection prevention and control practices. Per the CDC guidance, facilities may want to consider limiting exposure of pregnant healthcare providers to patients with confirmed or suspected COVID-19, especially during higher risk procedures, such as the aerosol generating procedures we discussed earlier, if this is feasible based on staffing availability. Next slide, please. This is currently the policy at LPCH Stanford for pregnant healthcare providers, that pregnant providers and staff should limit whenever possible direct care of patients with confirmed or suspected COVID-19. The available data doesn't support removing pregnant providers from the workforce at this time. However, this would be reassessed if additional data became available. And it's our recommendation that pregnant staff avoid all in-person patient contact after 37 weeks to decrease the maternal infection risk. And this would therefore decrease the chance of mother-infant separation after birth if the mother were to become COVID-19 positive. And again, these are just the recommendations that we are currently employing at Stanford. I'm going to pass it over to Henry Lee for some closing remarks.
Thanks, Kelley, and thank you to all the speakers for just sharing with us the practices that Lucille Packard Stanford has adopted, and just being in the thick of it these past few weeks as the counties surrounding us have been affected quite a bit. And so really appreciate your time and expertise. And just to recognize, I know there's been a lot of questions on the chat, and we got a lot of questions already from our registration. So we tried to answer a lot of them during the presentations, and we'll do a little bit more for the next 10 minutes. But we'll follow up. The slides will be posted, as well as the recording of this webinar on the website, which will show the website in a couple of slides. Go to the next slide, please. For those of you in California, we would like to continue to work with you and be a resource, as well as learn from you. So please you can email me or just go on our website to contact us. And for the California maternity hospitals, we would also like to keep track of if you do have maternal or neonatal cases of COVID-19, and we'll reach out to probably each of you individually. But if you are the main contact who would be keeping track of that, please note this email there for Jennifer Kang, or you can email me as well. Any cases, or just creating a line of communication with us. And then as well, we'll probably end up having more info to come on both on the website, perhaps another webinar. So if you have some really pressing issues, please feel free to contact us about that as well. And yes, we are posting these slides as well as the webinar recording soon on our website. So with that, I know we have the ability to answer some questions, and so I'm going to hand over to Christina for the next 10 minutes.
Thank you, Henry. This is Christina Oldini. I'm Associate Director of Programs out of CMQCC. We have spent much time going through the hundreds of questions that were submitted pre-webinar, and I've been also reviewing some of the questions that have come in live. So what I'd like to do is Dr. Aziz, and maybe with the backup of Kay and Elliot, I'd like to do, let's get us started with what I would call a rapid fire session. And so what I'm looking for here are as quickly as you can answer these questions, but these are very common questions that came in before the webinar. So if you could take yourselves off mute, Elliot, Kay, Natali, at this point, that would be wonderful. Natali, can you go ahead and speak to the use of nitrous as supplemental O2 oxygen? Does this increase the risk of aerosolizing the virus?
It does, and we have at this time suspended it at our hospital for the time being until we have more data and with respect to aerosolization. However, it is one of the procedures considered aerosol generating, yes.
Nitrous, what about supplemental O2, for example, for decelerations?
No, the supplemental O2 would not be, but nitrous is given the mode of administration.
Perfect. Can you speak to the use of ibuprofen?
Oh, I think, the data is difficult to interpret. For now, I think it's fine to avoid it. However, the pathophysiology is a little murky. So I think that we need more research on this and more data on this. However, at this time, I think, in order to keep us as healthy as possible, we should avoid as much as possible.
Couple more and then I'll give you a break. Is second stage aerosol generating? And if so, what about PPE?
So this was something that Ms. Kelley, Brennan, and I were discussing today. We do think that second stage per se, perhaps not necessarily just the pushing portion of a pregnant patient, but the implications of, once a infant is delivered, the infant may need intubation, or in case a stat C-section is needed and there is an emergent rush to the OR. So we at our hospital are using PPE with all COVID-19 positive or PUI patients on labor and delivery, because any technical admission to generate a aerosol generating procedure such as an intubation for a stat C-section. But yes, on second stage, definitely that we are using N95 for that portion as well.
Last two, delayed cord clamping.
Was that for me or?
Yeah. Any
So we don't have any data to support vertical transmission. There have not been, at this time, we have had a total of actually 97 cases total reported of infant deliveries to COVID positive mothers, 3 large case series larger case series, and then 2 case reports. And given that we don't have data to demonstrate that there's vertical transmission, I don't think it's a contraindication at this time, and neither is breastfeeding. I wanted to just make that there has not been any virus found in breast milk either. So to date, with the limited data that we have not been able to demonstrate intrauterine transmission or vertical transmission by testing of amniotic fluid and then infants after delivery. And then we have not been able to demonstrate breastfeeding transmission through testing of breast milk.
Perfect. Birthing in tubs.
Again, given that we don't think there's vertical transmission, I would say that at this time, we don't have a contraindication to it, but I would just please caution everybody to keep their ears and eyes out for the CDC and anything else that you use as your resource of practice guidance, because the data is very limited. And one of the things too is that unfortunately, I think so much is, efforts are spent on severe morbidity and mortality that I think pregnancy data is probably a little bit slower to be released as well. So I think, we still need more data, but at this time it's not contraindicated.
Christine, I just want to clarify, are they asking about a water birth or laboring in, because I think the water birth issue may be a little bit different than laboring in.
Either.
Natali, I'm just wondering about the issue of stool and as a mode of transmission.
Well, I think that if, again, those are theoretic, and I believe Dr. Our pediatric colleague did say that they were theoretic. I think you could, yes. So I think you can, speak with your pediatricians and see what their thoughts are regarding mode of transmission. But at this time, we don't think that, we don't have data that typically at this time it's theoretic.
Perfect. Roshni, I'm going to ask you to come aboard now. And I've got very important questions and I'm going to ask you to summarize here. Explain what a staff tracer sheet is and why it's important.
So it is just a document essentially to make sure that we have an idea about who's been going in and out of the room, just in case the patient turns out to be positive, making sure that appropriate personal protective equipment was used and there is no risk for exposure. So it's essentially just a sheet of paper that has that information.
Okay, so I'll speak with the speakers after. Perhaps we could provide an example of that. Same presenter, Roshni. Address the floating of staff between OB and newborn care units and peds or med surg. So as Kay spoke earlier, I'd like to look at from the opposite. These are OB, NICU or newborn nurses going to PICU, going to peds, going to med surg. What about the concern about returning to our settings after they've been floated?
So I don't know if I'm the right person to answer this question, but technically if they have an exposure while at a different setting, hopefully they will be contacted as part of the exposure investigation, and they would follow the recommendations of the institution about how to go back to work, which setting you can go back to work in. Like, for example, at our hospital, you can return to work with a mask in place if you're asymptomatic, but you cannot care for immunocompromised hosts. So there would have to be some sort of an idea about if there is an exposure, how do we handle that if the exposure happened in this new setting that this person was floated to?
Okay, last question, and I'm going to ask Natali, a lot of pressure here, but I just, if you could think in your mind, your triage mind, a couple bullet points is what I want from you. If the supply of PPE is limited, where are these key points of contact that it must be worn? So if you're limiting it, what are the bullet points?
You are putting me on a really dicey platform here. Yeah. So I would love to include everybody in this in this discussion so I can take the heat off myself. But I would say, so Ms. Kelley, Brennan again, and I were discussing that. So if something is non-aerosol generating, let's say you have a postpartum patient that is very stable, she is not using nebulizer, she's not on CPAP, so that would be, and has been very stable postpartum, that would be a situation where an N95 may be substituted instead for a surgical mask so that we can conserve PPE that is needed elsewhere for higher acuity infection risk scenarios. Other things would be, obviously, if someone is at greater than 6 feet distance from you, and obviously that 6 foot distance puts you at less contact in terms of secretions or other particles from droplet precautions, basically. So if one were to need to, give up a gown, for example, I suppose being greater than 6 feet apart might be a scenario where that might be considered. Dr. Mathew and Ms. Brennan, do you have any other thoughts about this? I think it's a tough question, but I think we have to face it, obviously.
This is Roshni, Mathew. Thank you, Dr. Aziz. That is exactly correct. I would just reiterate that the mode of transmission of this virus is considered to be most likely droplet transmission. The wearing of N95 is very specific for instances where aerosol generating procedure is expected, and it is a very conservative approach which CDC has recommended. That is still the guidance we are all following, but essentially this virus is transmitted through droplet transmission, and thus the 6 feet, because if it was airborne, we would not be saying 6 feet.
Thank you. And before we close off today, again, this is Christina. I first of all really want to recognize all the speakers. They came, all of these are active caregivers, active clinicians caring for patients. We want to recognize their service to those patients, and we want to thank them for taking these questions in a very tough situation. We also note that these are examples from Stanford Healthcare in our setting. Please remember, settings are different. Stay up. It's on everybody to stay up with the recommendations out of the CDC and the other recommendations we have posted on the California perinatalprograms.org website. Again, thank you all. We wish everybody well. Stay safe out there. And thank you for caring for patients.